It gives me great pleasure to introduce Ara Tekian. He's a professor of medical education at the University of Illinois, Chicago. He's the head of, I'm going to get this wrong now, I should have looked at it, International Affairs or International Studies for the Masters of Health Professions Education program. Because it's 5:28, I'm going to spare you summarizing his 88-page CV, but I think he's internationally known. He's given numerous international talks. He's considered an expert, preeminent expert in simulation-based medical education and medical education in general. I can also tell from personal experience, he's a wonderful mentor and research collaborator. So I think we'll all enjoy hearing his take on radiation oncology education. So let me pull up the talk for you. And then the down button goes forward.
Well, thank you very much, and I'm impressed of your patience that at 5:30 still you are ready to listen to a keynote. And I have to first congratulations for putting this program together. When I looked at the program and I saw 34 presentations, I said in my life I have never attended in one day 34 oral presentations. So this is a record. I don't know with any other group this will ever happen, but it's impressive. And also, but thank you for the lady who introduced my country. I'm Armenian by origin, and now you know on the map where is Armenia. This has never happened, and I was surprised. All of a sudden, many people say, "From where are you?" and you have an accent and so on, but they have never even heard about Armenia and so on. So, in being introduced, it was very nice. The talk today is, I will try to talk about simulation. And the way I organize, there's a lot of things that we can tell, but I will briefly tell how we classify simulators, and then focus a little bit on conceptual frameworks related to simulation that will help you understand the teaching and assessment and some measurement considerations. And special thanks to three particularly colleagues, Jack Boulet, Matt Landry, and Kevin Eva, who had shared a few nice slides with me, so welcome. This is a book that I had published with two of my colleagues, Innovative Simulations for Assessing Professional Competence, from paper and pencil to virtual reality. This was 20 years ago, and even the work started prior to that. This is 1999 published, and there was a lot of interest at the time, what is happening. And this book examines simulation across all professions, from medicine to architecture to military to aviation and so on. And the working definition that we started was the simulations are approximations to reality that require training to react to problems or conditions as they would under genuine circumstances. Three important characteristics that up till now it's very important when you are using simulation. They imitate, but they do not duplicate reality. They offer limitless opportunity to go wrong, and there is no harm happening. They provide corrective feedback. And a lot of simulation literature, when you review, these are very important characteristics. So if we look based on the characteristics, a number of very important advantages: decreases risk to patients, enables deliberate practice, it's safe to learn from errors, it's a controlled environment, a lot of learning outcomes could be addressed, and can create relevant simulations when required. So the potential applications. It can be used for training individuals or teams, and you can practice it in very complex clinical situations. You can rehearse serious or rare events. Rehearsal of planned novel or infrequent interventions could be done through simulation. And learning and rehearsal of clinical and communication skills at all levels, particularly the communication component. And you can do training of teams in crisis resource management. And a lot of the early science that comes is from aviation, particularly from crisis resource management. Now, this is a classification. After studying all what has been done, I have put it this classification, and we'll go each one of them so that the terminology we use is clear right up front. Part as trainers is part of the body that we take, and mostly it is used for procedural or technical skills. It can be low fidelity, like insertion of an IV, or high fidelity, like all those use the Harvey Mannequin for the cardiac simulator. Then we have the virtual reality, but with haptic simulators. This is physical representation with sensing instruments that inform the computer of the user's movement, and it's a three-dimensional representation. And we have, let's say, we use it for precision, like IV cannulation, or simple manipulation, endoscopy, for example, training comes under this, or very complex one, complex surgical procedures. Now, there are computer-based systems with mannequins, and over here learners are provided with interfaces that allow them to interact with materials related to basic sciences, and they receive feedback. A lot of this is used in emergency medicine or anesthesia simulators. Then there is the integrated simulators, and this combine a whole or part body mannequin with computer that controls the model's physiology and the output to monitors showing graphic displays. And the vital signs could be controlled and altered in response to interventions, where that's the advantage. It could be instructor-driven, or it could be model-driven, like the METI simulators. Screen-based simulators, it's another, these are the desktop simulators. These are very popular in medical schools because it contains a lot of scenarios and the students can sit down and practice. The advantage is that when you, whatever steps you take, you get the computer stores that information and then provides the feedback how well you did, and when you did not do a right step, why it was wrong and what will be the consequences. So the students like this immediate feedback, and they use the screen-based simulators. Standardized simulated patients, we have standardized, or when we say simulated it's with without any history or physical. So this, you are basically simulating but standardized patients. They can be patients with real history. So it's almost in every medical school there is the use of standardized patients are very common because part of the USMLE Step 2 clinical skills component use standardized patients. Simulated environments, this is mostly like the past 2 decades, I will say. It's basically recreating a clinical setting, and particularly, let's say, operating room, intensive care units, where you can simulate, you can videotape what is going on, and then during a debriefing session, you can freeze any component and start the discussion. Very useful, and The students and even residents like it a lot. Here you see, and the setting up is very easy. You don't have to really be in an emergency room and so on. You just can put a screen and then play any role. Finally, the last group that I have is the hybrid simulation. This is more and more becoming popular because you don't want only to let the students practice on the model, but you want to put a patient. Here, for example, let's say the delivery, the model, the standardized patient over here is sitting in a folded position, and let's say the entire procedure is happening. But the important thing is how the resident communicates with the patient. And when we were in one of the, let's say, experiments we were doing, a resident performed completely the procedure, delivered the baby, and put it on the side. And the patient started crying. He was surprised, and then he said, "Oh, I did something wrong." And the mother said, "Where is my baby? Is my baby?" So completely there was no communication. It was so powerful that sometimes you need to do, and there is a lot of this hybrid simulators going on. Now, this one paper, actually it's a systematic review that Dan was supervising, and Michael Rooney took the lead. It was nice to really analyze the literature of that dealt with radiation oncology and simulation based. And that was when I started closely looking at radiation oncology, because I have looked at all other specialties, but now I am just, I don't know, after all these 34 papers, I even talk about radiation oncology, not being even a radiation oncologist. But the nice thing is that there is all the classification of how these papers, what they have done. It was more than 400, maybe 75 papers, cut down to eventually 54. So it has a lot of information. And look, and then this was still from 1990 up till 2017 December. In 2018 submitted and published. And I have looked what has been published also. I have some concerns about the published papers in radiation oncology. Sometimes they are very important papers, but then there's a lot to be said. And looking at those papers, I was thinking, where is it that people might really benefit from a discussion? And I thought that maybe I have to talk a little bit about conceptual frameworks, how they inform the teaching assessment, and also a lot of things that you presented. I consider many projects that were presented today, they can be published, but they need to be put in a let's say, format that is acceptable for publication. And one area is you can put the conceptual framework, and we'll tell what they are and which ones you are familiar with, and so on. So start thinking, since we are talking also about simulation, how difficult should simulation-based practice be? Because we are involving, in the students and residents. And how much does fidelity matter for learning? Because we have low fidelity, high fidelity, when, why, and how much practice is enough given an objective? 10 hours, 100 hours, 10,000 hours, what is it? So the literature informs us a lot, and we'll go there. Now, when we talk about conceptual frameworks, here we are talking about theories. They tell us something about what we answer. These are like lenses. Through what lens I am looking at my study? Is it theories or taxonomies or some best practices or ways of thinking about a problem or representing how complex things might work? It's good that in one of the curriculum presentations a conceptual framework was used, David Kahn's 6-step approach for curriculum development. I was very happy. But a lot of times the conceptual framework was absent. And if you want to go into the high-impact journals, you need to base your study on some conceptual framework. So here there is one review for all those who are interested. It's about mastery learning in health professionals using technology-enhanced simulations. And this is by David Cook and colleagues, where they were saying that the mastery learning models incorporating instructional design features would be more effective. The mastery learning models without these features, and we'll talk about these features, includes the instructional design features, feedback, repetition, longer time spent in learning, and we'll go more in depth. So these features of mastery learning are important in whatever you are doing. If your aim is to make sure that at the end they have mastered a skill, a procedure, whatever. There is baseline assessment. There has to be very clearly defined objectives. The instruction has to align with the objectives, not the objective saying something, instruction is something else. There has to be some reassessment after your instruction, and standard setting a lot of time is not done. What is that minimum pass that is acceptable, below which that performance is unacceptable? And how do you set that standard? And the progression to the next unit only after achievement, after passing standards. So that's why it is important. How can you continue on when I don't know if you have passed that minimum standard, and continue to practice if the minimum passing, let's say, standard was not achieved. So what is simulation-based mastery learning? It assumes all learners can become eventually masters given sufficient time and appropriate instruction. But however, mastery should be defined because there are different definitions, and it, let's say, we'll not cover these 7, which are very similar. But another one is Erickson's deliberate practice with feedback. This is very important because he has studied a whole number of, let's say, performers, from sports to musicians, from chess player, and then Olympic game participants. So give a task with a well-defined goals, motivated to improve, invest in their performance, account for pre-existing knowledge when you are designing the task, provide immediate feedback, and opportunities for repetition and refinement of performance is very important. Here, for example, in one of his earlier studies in 2008, he was saying that it is just when you are trying to improve your performance, you try to practice and experience, so you come to the everyday skills, which is just almost getting the skill. But arrested development, it always becomes automated. And then some people will go all the way to the expert performance. But somewhere, if you want to put a standard, we'll say that, okay, this is where it is the step. Below this it is unacceptable, is not competent. Here, the one example that gives that how many hours you need to practice. For example, this mastery requires 10 years, and Michael Jordan, for example, you know how many times he shoots the ball per day when he was? 500. And it has taken years and years, 10,000 even hours of practice. Now it says over here about 10 years. But until you get really at that level, it's a lot of work. So when we put over here, I put since let's say ACGME adopted the Hubert Dreyfus model of novice to master as the let's say initial assessment model. This is in 1999 when ACGME released the 6 ACGME competencies. They said to Dreyfus, with all 20 years of experience, how can we assess the competencies? What is the minimum? And from his, let's say, framework, he said at a minimum, the resident has to be competent, below which cannot pass. But it can be competent, proficient, or expert. So that's the zone which is safe for postgraduate studies. Called experiential learning, when you are basically using simulation to teach, it's a nice model because you have concrete, let's say, experimentation, clear objectives, standard setting, and then you observe and reflect. Did they achieve the standard? You provide feedback with some deliberate practice, and then you look at, you start abstracting concepts and starting generalizing. This is where the formative assessment comes in place. More feedback and deliberate practice, and then you will go to the testing back again the concepts, and then the cycle goes back again. So it's a very nice way of explaining another conceptual framework how learning happens. Now, when you are developing a curriculum and your intention is mastery, and from entry until graduation of the resident, you might look at the milestones, or it's very similar in Canada as well with the CanMed roles. Setting standards is very important, but also thoughts about practice and remediation. We are observing the progression. Where is the individual not doing well, and that I have to interfere and improve it? Now, let's say, Rohrer and Peschler have done 20 years of research on memory retrieval, distributed practice, spacing in learning, and so on. And let's say they have come out that, let's say, mastery learner strategies definitely improve learning and retention, and unfortunately they are not much incorporated in the students' learning habits. Now, learning through testing is particularly formative, and it enhances learning and slows forgetting. There are articles, and one of them was published 2 years ago in JAMA. What it says, basically, the whole thing: the more you create opportunities to retrieve information which is stored in your brain, the better it becomes. So basically, providing some formative feedback and then creating another such situation where you are retrieving information, the individual is learning, it's going to the long-term memory. So basically, there are very nice studies, but two of them I have cited. The second one by one of our students, recognizing an answer, for example, in an MCQ is not as effective as recalling an answer. What you are doing is retrieving that information which was stored, and that's what is helping. The mixed practice, let's say you are learning about circulatory items and practicing, and then undigested items. But when you start, let's say, integrating these, your learning will be much better. So mixed practice basically promotes discrimination and integration, and requires learners to activate different memory structures. Spaced practice, let's say, how do you really space? Let me show you, first of all, CPIDA has done a number of studies, but one of them, he says that if you are just studying the last minute for an exam, yes, you will remember. And he has this formula that, let's say, if your exam is after 1 day, it is your recall is between 0.1 and the X is the days, if this one, to 0.3, that you can remember. However, let's say, the important question is, when should I study to maximize retention and minimize study time, hoping to retain information into the indefinite future? Here, for example, this is the decay in recall probability. And if, let's say, later that same day, recall is effortless. So there is little benefit. But if I, let's say, a week later, information is all has been forgotten and must be relearned, if these are, let's say, difficult skills. But if I am doing, let's say, I studied and then 1 day later I'm recalling, the recall is likely, but takes mental efforts and minimum benefit, maximum benefit. Now, if you look at this starting point, my retrieval, at that day, let's say 1, I have studied and then I am forgetting. Then, let's say, if I review one more time after, let's say, 2 days, I am getting back again. What I did was I retrieved the information that was stored in my brain. And then after some time, there is decay, and then I back again review, and then that goes into the long-term memory. Now with this few, let's say, conceptual frameworks, how are the spacing and testing effects related to cognitive load theory, which I will mention? Cognitive load is the working memory, how much you can put it. For example, today, with these 34 papers, where is it? Our cognitive load, it is exploding, and and how well they are spaced, mixed, and so on. One important framework also is the stages of formal learning. This I will not go over because this is the Gagne's 8 stages learning. If you put Gagne in the literature, it's very important there, but it says clarify objectives. I will go very quickly over this, and I have a summary slide here. So basically, it's very important, the 8 steps. Each one of them you will really relate if you read this one. Cognitive load theory, more and more this is coming, and that's why I included. The working memory is very limited. And usually the research says that anywhere 2 to 4 new elements, concepts at a time you can get it. And everything gets lost. When you are hearing something you are not processing in your mind, that is gone. So rehearsal is very important. And people, when they are teaching, they have to be careful, doesn't matter in what setting you are. There are 3 different types of different instructional loads. One of them we call it intrinsic load. This is due to the complexity of the concept. For example, learning vocabulary versus the grammar. And if we look at the working memory, so we have the intrinsic load. Next, we have extraneous load, which is due to poor, let's say, maybe instructional material practices. For example, if it is very hard to read the fonts or there are too many distractors, it's extraneous. And so that's in your working memory, there's that extraneous component. And then there is the germane load. And germane load is due to the learner's mental effort to understand the material. Here, this is what you are doing your best to really learn the skill and whatever is being presented, combining concepts into a mental model. So they're germane. Now we want, how can we reduce the extraneous, let's say, load and increase the germane load? So let's say extraneous, you can make, let's say, cases with correct differential diagnosis, fill in the blanks, and so on. You are making it easier instead of creating that difficult, complex situation. Put all information needed in one place and don't overload. The intrinsic load is move from simple to complex concepts, from low fidelity to high fidelity. And eventually, that's what we are interested in, the germane load, present problems with varied features, same clinical symptoms, but different, let's say, age, sex, or prompt learners to explain phenomena and gradually reduce guidance. So, here the key is get the learner's mind to wrestle with the material, and that's how they learn. And it's nice to start thinking, if you are using simulation, what is the cognitive, how is cognitive load managed in your simulation-based, let's say, the training activities, and how it might be managed. One thing, since we've, let's say, talked about massed versus spaced, teaching everything in one day or versus spacing, here there is a lot of research that you can learn faster and you have higher confidence and greater satisfaction with the massed learning. But when it comes to retention and performance, it's better if it is spaced. And there's so much of evidence. This is the summary of the whole literature, mass versus space. Dual processing, I will not do all this one because it takes time. Here, only a few slides and done. Measurement, because we talk about the conceptual frameworks, but there are issues with measurement. You need to pay attention, how do you score a performance, and how can you generalize the results? Is there any reliability, reproducibility, and how you can extrapolate? Are you measuring what you intend to measure? So there are 3 slides, one on each one, and then we are done. So the types of the scores, it's either basically the score based on the process or outcome. For the process, explicitly we use checklists, and the implicit, it's the rating scales where there's more, let's say, how well something is done. And if you are looking at the outcome, you are looking like patient status and so on. Reliability, how consistent are the examinee's training score? Let's say here I put a table. You can have, if you have 5 cases, if you have 5 judges, you can have, let's say, one case all observed by 5 judges, or you can have one judge observing all the cases, or you can have each judge observe one case. Which one will be the best return for you? A, B, or C? Or none? I don't know if at this moment you can start reasoning. It is after, it's already 6. C, yes, definitely. You get much better of your use of your judges and the cases. One judge with each case is much better than the other 2. And finally, validity, it's the providing evidence. Basically, are you measuring what you intend to measure? And there are a whole number of frameworks that can guide you step by step. Thank you very much for your patience. I know it's end of the day. Feeling guilty that now how should I, after 34 presentations, still go ahead and talk about theories and so on, but you are a great audience. My respect is increased towards radiation oncologists who have such a stamina. Thank you very much. And please keep on publishing what you are presenting. Yeah, maybe that's where you need a little help. Yeah, to improve the quality. Anyway, thank you.
Does anybody have any questions or?